This is Audible Bleeding, the Vascular Surgery Podcast. We're here to help you keep your finger on the pulse. Welcome back to Audible Bleeding. We are at the Vascular Annual Meeting 2019 in Washington, D.C., and we're going to bring you some highlights of interesting things happening here. First, we have Dr. Lombardi, who will be discussing the results of the STS 2 trial and a new classification system for aortic dissections. Dr. Joseph Lombardi is a professor of surgery at Cooper Medical School and the head of the Division of Vascular and Endovascular Surgery at Cooper University. He is the PI of the STS 2 trial on endovascular treatment of acute, complicated Type B aortic dissections with a composite graft design. Welcome, Dr. Lombardi, to Audible Bleeding.
Thanks, Kevin. Good to be here.
So, Dr. Lombardi, the Cooke Zenith dissection endovascular stent was just FDA approved. Where does this fit in your practice?
Well, I try to use it for all dissections when I can. I think the data speaks for early initial management, given the low mortality rates, low paraplegia rates. I think in comparison to other bodies of data, this is very favorable with what's out on the market. So I try to use it religiously, with the exception of acute rupture. I might decide to extend the thoracic aorta down to the celiac with a covered stent graft and then see where the patient goes from there. But if the patient has concomitant malperfusion, then I'll add a dissection stent to take care of that.
And what's the purpose of the Bair Stent? How does this stent differ from other stents on the market right now for thoracic interventions?
So this is a composite device design, so it's meant to cover the primary entry tear in a minimal fashion. So extensive thoracic aortic coverage is really not warranted when you're using the dissection stent. So that preserves a number of vital intercostal arteries in the descending thoracic aorta. Hence, that's why the paraplegia rates were so low in stable 1. So we use the distal dissection stent to help remodel the true lumen. And subsequently, what you find is over time, the true lumen remodels very favorably and assumes its normal configuration and diameter that started before the dissection occurred.
Dr. Lombardi, for our listeners out there that aren't familiar with the STS 2 trial, can you let us know what the focus of this investigation was?
So we were looking to treat complicated Type B dissections. There were dissections that were either rupture or malperfusion, no other variations, no high-risk patients, and certainly no uncomplicated patients. So patients with rupture or malperfusion were enrolled in the trial. It was a multinational trial. And then we had a 30-day endpoint for mortality. And then we also had the ability to follow these patients long-term over 5 years. And so it was a specific study to look at that composite device design with short coverage, covering that primary entry tear, and then extending the dissection stent based on the patient's anatomical configuration at the time of presentation. So if you look at the stable trial implants, you'll find that there's a multitude of different combinations used, from 2 stent grafts to 3 stent grafts and 1 dissection stent to 1 stent graft and 3 dissection stents. So it really gave the investigators a good variety of pieces to assemble based on the patient's presentation.
And what are the main takeaways from the STS 2 trial?
Yeah, I'm fascinated by the low mortality and paraplegia rates, but I'll tell you, I'm also fascinated with the ability of getting back into that stent or across that stent for secondary reinterventions in the event that you have aneurysmal growth for Type Bs, which we are finding is more and more prevalent as we follow patients longitudinally.
So can you elaborate on that?
Yeah, so we wrote a paper recently. It was a systematic review of a number of published reports on aortic remodeling. And so we did both the thoracic aorta and abdominal aorta, and we found after 84 publications, there were only 17 publications that were speaking apples to apples. So we got that data and we found over 1,000 patients with the thoracic aortic measurements and found that over time, there was approximately 34% increase in size over time. So there was an aortic growth demonstrated with TVAR. And the abdominal aorta, which is less frequently described in the literature, also had about a 35% growth rate. So this triggered us to be more proactive in our surveillance of patients after TVAR for dissection. In addition, you're going to need to be set up pretty well for success in the event that does happen. And when you have a dissection stent across the visceral segment, it acts like an in situ fenestrated stent graft. So you get across the orifice that used to be in line with the target vessel, whether it's the left renal or an SMA, and then you're able to bridge that to the true lumen with a covered stent. And then you can shut down false lumen flow, or have the ability to get into the false lumen and do direct false lumen adjuncts to promote false lumen thrombosis.
Joe, tomorrow you're giving a talk discussing a new classification for a system for dissections. Can you give us some insight into the process of developing this classification system?
A good segue, Sharif. You in the process of putting that meta-analysis or systematic review together, it was mind-boggling how many different definitions there were of the same process. No one was speaking the same language when describing dissection or longitudinal long-term results. So after that frustrating experience, we were happy we were able to get some good data for the systematic review, but we were very unhappy the fact that everyone wasn't really kind of speaking the same language to describe it. So for future references or for future types of descriptions, we were hoping that we could come up with a language that was universal and commonly used among people interested in treating dissection and reporting.
So which groups were involved in the reporting standards?
So we initially brought our idea to the writing doc committee at the SVS, which was headed by Tom Forbes. He was very instructional on how to get a proposal together. And in that proposal, we included the Society of Thoracic Surgery, and then asked 6 members from the Society of Thoracic Surgery and 6 members from the Society of Vascular Surgery to get together and form a writing group. We paired the thoracic and vascular surgeons together, and they all participated in writing sections of the document. And then Chad Hughes, who is my co-director of this effort, also helped edit and put together the manuscript with me.
When a new classification system comes out, it can muddy the waters for evaluating previous trials. How does this fit in with old classification systems? Is there an ability to go back and modify previous studies to incorporate with this data?
Yeah, that's a great question. I think one of the nice things that we know from the Stanford and DeBakey classification systems is that they were not mutually exclusive. I think you had bodies of people that still like to use the DeBakey system and those that still like to use the Stanford system. And likewise, this new classification system is going to provide another tool, and a more descriptive tool at that, for looking specifically at Type B and Type A aortic dissections, more relevant to the way we're treating patients today, and that's with TEVAR and endovascular techniques. So I think those who have a great interest in endovascular or dissection repair are going to be drawn to this due to its ability to get down in the weeds and describe it in detail.
So what are we calling this new classification system?
It's the SVS STS Classification System.
Could you describe it in a nutshell?
No, I think it's easily described because the Type A and Type B varieties are still going to be present. What distinguishes the two is the location of the entry tear, not location of disease process, but location of the entry tear. So if there's an entry tear in the zone 0, that's a Type A. If there's an entry tear in zones 1 or greater, it's a Type B. And that differs because it's not the left subclavian artery anymore comparison to the Stanford classification. So then you can describe the extent of the dissections. If it's an A, you look at the dissection extent down to zone 8 or 9 or 10, and then it's an 8-9. It's an A9. And then you can, in your head, you can picture that. For Type B dissections, we are very keen on describing the aortic arch because there's a lot of proximal extent Type Bs that go to zone 2 and sometimes zone 1. And so if you have a Type B dissection with an entry tear distal to zone 1, then you're going to, and the extent of the dissection is zone 1 and zone 9. So it's a B19. So you have 3 pieces of information. You have proximal and distal extent, and you know the entry tear location. So we figured that was a very facile way of people communicating to one another regarding the disease process.
Congratulations, and thank you for breaking this down for us on audible bleeding.
Thanks a lot, guys. Appreciate it.
I'd just like to let our audience know of a way to support our podcast. Our team is committed to providing free, high-quality, unbiased content to our listeners. We currently do not take any funding from industry sponsors or advertising, and we hope to keep it that way. So if you want to help us keep bringing you great content, go to audiblebleeding.com/support and find out how. We'll put a link in our show notes.